You are now muted.
Integrated Care Resource Center. Thank you for joining us this afternoon for today's study hall call on state perspectives on contracting with dual-eligible special needs plans, also known as DSNPs. In this study hall call, Rebecca Lester from the Integrated Care Resource Center will share highlights from a new ICRC TA tool titled State Contracting with Medicare Advantage Dual-Eligible Special Needs Plans, Issues and Options. The link to the tool can be found in the body of today's appointment as well as in the slides. We will also be joined by and hear from representatives from Minnesota, New Jersey, and Tennessee. Pam Parker, Sue Cavendrew, Patty Killingsworth, and Elizabeth Wood will share insights from their wide range of experience in state contracting with DSNPs. Their brief bios can be found in the body of today's appointment. Jim Verdier from the Integrated Care Resource Center will moderate a panel discussion with these featured speakers. All of our speakers will be available at the end of the presentation to answer your questions and participate in the discussion. Before I turn things over to Rebecca, I would like to find out who has joined us today. Would one representative from each state please respond here rather than telling us the names of everyone on the call? And if I miss your state, I apologize in advance.
You are no longer muted.
Okay, so I'm going to go ahead and begin our roll call. Alabama, Alaska, Arizona, Arkansas.
Here.
California, Colorado.
Yes.
Thank you. Connecticut, Delaware, Florida.
Here.
Thank you. Georgia, Hawaii.
We're here.
Thank you. Idaho.
Here.
Got it. Illinois.
Here.
Indiana. Iowa. Kansas. Kentucky. Louisiana. Maine. Maryland. Massachusetts, Michigan, Minnesota.
We're here.
Oh, thank you. Mississippi, Missouri, Montana, Nebraska, Nevada.
Nevada is here.
Thank you. New Hampshire, New Jersey.
We're here.
Thank you. New Mexico, New York.
Here.
North Carolina, North Dakota, Ohio.
Ohio's here.
Thank you. Oklahoma, Oregon, Pennsylvania, Rhode Island.
Here.
Thank you. South Carolina.
Here.
Thank you. South Dakota, Tennessee.
Here.
Oh, thank you. I got Tennessee. Texas, Utah, Vermont, Virginia.
Here.
Thank you. Washington, West Virginia, Wisconsin, and last but not least, Wyoming. Okay, are there any states on the line? Oh,
Yeah, I apologize. I'm from Pennsylvania.
Thank you. Are
And
there
this
any?
is Illinois.
Got Illinois. Is there anyone else? I think we have a few folks still joining in, so we may do another check later in the call. So before we get started, I'd like to quickly go over a few of our logistics. To eliminate
You are now muted.
phone lines are being muted today during the presentation, but we will have a Q&A session during today's event. If you would like to submit a question during
You are now muted.
then you may use the Q&A feature. There is a Q&A icon in the drop-down menu of the toolbar at the top of your screen. This slide gives you a screenshot of what the toolbar looks like.
You are now muted.
Lastly, I wanted to mention that we will be recording this call, so your state colleagues who are unable to join will be able to listen to the recording at a later date. And at this time, I'd like to turn it over to Rebecca Lester to begin today's presentation. And thank you.
Okay, thanks, Anne-Marie. So in this section of the Study Hall call, I'm going to give just a very brief overview of the purpose and history of DSNPs, describe briefly the technical assistance tool that the ICRC recently developed on state options for DSNP contracting, and then I'll give some really high-level examples of how some states are using these contracts. And our panelists will talk in more depth about some of the contract options that I'll review in this section during the discussion and portion of the Study Hall call. Next slide, please. So a dual eligible special needs plan, or DSNP, is a type of Medicare Advantage prescription drug plan that focuses on the needs of individuals duly enrolled in Medicare and Medicaid. And the purpose of DSNPs is to coordinate care for these Medicare and Medicaid enrollees and provide a model of care that's focused on the special characteristics and needs of this population. So like all Medicare Advantage plans, DSNPs have always been required to have contracts with CMS that specify the services they will provide and other features such as program operations and data collection and reporting requirements. However, starting in 2013, for the first time, DSNPs were required to also have contracts with states. This requirement was a part of the Medicare Improvements for Patients and Providers Act, or MIPA. MIPA outlines some pretty basic requirements for the contents of these contracts, and those are described on the slide. They included the DSNP's responsibility to provide or arrange for Medicaid benefits for their enrollees, beneficiary cost-sharing protections, requirements around information sharing with the state for verifying Medicaid eligibility, and MIPA also required that DSNP contracts specify the service area covered in the contract period. So the MIPA requirement created an important new opportunity for state efforts to integrate Medicare and Medicaid services, because for the first time, states had the authority and a specific platform to work with DSNPs to develop contracts that incorporated plan design and operations that supported better alignment of Medicare and Medicaid services and could further the goals of the state and Medicaid agency around quality and coordination and access to care. In calendar year 2015, there are 336 DSNPs operating in 38 states. However, enrollment is concentrated with about 2/3 of enrollment in just 11 states. And the next several slides are going to provide a very high-level overview of the technical assistance tool and some of our key findings of that analysis. And then, as I mentioned, I'll go over some examples of how states are using these contracts to go beyond the minimum MIPA requirements. Next slide, please. So as I alluded to, in addition to the basic MIPA requirements that we just discussed, states have the option to go beyond MIPA and incorporate additional elements into their state DSNP contracts to support more robust coordination and quality of care for Medicare and Medicaid enrollees. There's a variety of ways states can go about this. And the technical assistance tool that we at the ICRC developed highlights the range of approaches that several states have taken to incorporating these kind of robust coordination requirements. The tool that the ICRC created is based on analysis of MIPA contracts in 12 different states with a variety of approaches to DSNP contracting. And it's intended to be a resource for states that are considering their options around DSNP contracting. It includes reference tables that provide an overview of key contract features by states, and also an overview of characteristics of each state's Medicaid program for context. And the tool also provides examples of actual contract language, links to the full DSNP contracts we reviewed, so that states interested in learning more can take a look at the actual full-length contracts. So before moving on to walk through some examples of what we found in these contracts, I just want to highlight two key findings of our analysis. First, we have found that although our analysis included states with a wide range of approaches to DSNP contracting, states that have the most extensive DSNP contracts tend to have well-established Medicaid managed long-term services and supports programs, experienced DSNPs that are interested in contracting with the state, and state staff with knowledge of both Medicaid and Medicare managed care. The second key finding I wanted to note was that we found that states that align their DSNP and Medicaid contractors, in other words, have one single entity that operates both the DSNP and the Medicaid managed care plan in a given geographic area, put themselves in a strong position to increase care coordination through the aligned plans and to encourage enrollment of beneficiaries into these integrated programs. Next slide, please. So the kinds of requirements we found in the NIPA contracts we reviewed can kind of fall into three groups. The first is information sharing and notification requirements, which I'll discuss first. The second was care coordination and model of care requirements, and the third was administrative alignment. So as you can see, as I go through these slides, they each will contain reference to some specific state examples. And to find the details on those examples, you could review the page and the technical assistance tool reference on the slide. So I'll just review them at a higher level. Okay, so first focusing on information sharing and notification requirements, we found that almost all states include detailed information sharing and notification requirements in their contracts, and these generally fall into the categories of plan monitoring data, service use, quality data, and warnings of potential plan changes. States have very good reasons for including these types of requirements in their MIPA contracts. First, because some of these data, for example, grievance and appeals and service use or encounter data, can give the state an indication of the quality of care being provided by the DSNP and can also alert the state to potential problems with access, for example. It's also worth noting that DSNPs are required to submit a variety of quality and service use data to CMS, and also to submit any warnings of potential plan changes to CMS. So because DSNPs are already collecting and reporting these types of data to CMS in many cases, states are in a good position to also require that the DSNPs either simultaneously or in some fashion report the same data to them if they have the staff capacity to actually use and analyze the data. The second reason that collecting these types of data can be very important for states is that data around warnings of potential plan changes in particular can help ensure that states are aware of any pending changes to the DSNP that could affect continuity of care for Medicare and Medicaid enrollees. For example, states may require DSNPs to submit notifications of CMS warning letters that they have received for poor performance, or receipt of a low-performing icon for ongoing performance issues with a plan, or that they must alert the state of their plans for non-renewal of the DSNP contract or any planned service area changes. And clearly, states have an interest in receiving these types of data to anticipate and prepare for any types of changes that could affect beneficiary continuity of care. Next slide, please. So states with strong DSNP contracts also incorporate detailed care coordination and model of care requirements into their contracts. And these requirements generally target some of the key issues in coordination of care for Medicare and Medicaid enrollees. For example, lack of communication between the Medicare and Medicaid plan, things that can lead to confusion or uncoordinated services or delays in care for enrollees. In our analysis, we found lots of different examples of these types of care coordination requirements. And some of those examples include requiring that the DSNP and the Medicaid plan identify specific individuals at each plan that will coordinate and communicate when the benefit changes from Medicare to Medicaid, or requirements around communications at the time of hospital admissions or discharges. And also states may require involvement in development of the DSNP model of care. Next slide, please. So the third sort of bucket of requirements that we found in many states were administrative alignment requirements, and these are also commonly included in DSNP contracts. So generally, states include these requirements to address, again, the various ways that misalignment of Medicare and Medicaid requirements and processes can lead to confusion for enrollees and just added complexity for states. For example, separate enrollment processes and dates for Medicare and Medicaid products, or differing grievance and appeals processes and timeframes. And this slide presents just a few examples of the types of administrative alignment requirements we saw in our analysis of state DSNP contracts. These included, for example, requirements around developing integrated member materials in enrollment processes, integrated benefit determination processes, and aligning Medicare and Medicaid quality improvement activities. And again, our brief contains more details on sort of what these requirements look like and some of the considerations when developing them. So that concludes my portion of today's study hall call, and I'll now turn it back to you, Anne Mary.
Thank you, Rebecca, and for sharing, the background on DSNP contracting and the highlights from ICRC's new TA tool. At this time, I'd like to turn things over to Jim Verdier from the Integrated Care Resource Center as we turn to the moderated panel discussion portion of our call today.
Okay, thank you very much, Anne Mary. Could we go to the next slide, please? This, again, is a list of the state folks that you're about to hear from and the names of their managed long-term supports and services programs that they are either have or are in the process of linking to their DSNPs in the state. Could we go to the next slide, please? This is basic information from the 3 states on the first topic that we're going to ask our state participants to talk about, which is state approaches to alignment of DSNP and Medicaid programs. And what I'd like to do, since we have people whose efforts at alignment and DSNP contracting are at various stages, I'd like to start with Patty Killingsworth from Tennessee, who's kind of in an intermediate stage in terms of experience in aligning Medicaid and DSNP programs. And then to Elizabeth Wood from New Jersey, who's been doing it a little bit more recently. And then finally to Pam and Sue from Minnesota, who are the real old experienced hands in this. And what I'd like them to talk about in the next few minutes is the approach they've taken to aligning DSNPs with Medicaid programs, how extensive is the alignment that they've achieved so far, and how has it evolved over time. So Patty, let's start with you.
Okay, thanks so much. We have approached this really as our primary mechanism for improving coordination of care for dual eligible members. We withdrew from a financial alignment demonstration and really decided that the Part C and DSNP authority would be our tool for integration and coordination of care. So we really began in earnest in 2013 to look at alignment on two different levels. One of those is sort of a contracting perspective, and then the second one is really alignment at the member level and really trying to help ensure that members have the same health plan for both Medicaid and Medicare. From a contracting perspective, we recently went through a competitive procurement process, and as a part of that, for the first time, required that all of our Medicaid plans would also have a fully operational statewide DSNP by 2016, so that we would have the ability for alignment of membership as well as for contractual requirements. There are fairly extensive requirements that were a part of that competitive procurement process and that are now a part of the actual Medicaid contractor risk agreement as it pertains to our Medicaid plans and the coordination of care for dual eligible members. We also have a very extensive MIPA agreement that really, if you look at those three opportunities for focus, while we do get a lot of information from them and that information is really important, I would say that our primary focus has really been at that coordination level and how do we leverage those two contracts, our Medicaid managed care contract and our DSNP contract, to really promote those coordination efforts. The second piece of this, kind of stepping down from the contracting piece, is just the alignment of membership. And so there, in that competitive procurement process, as we were taking each of our existing MCOs who actually won the competitive procurement to a statewide operations level, we took that opportunity to align members wherever we could as a part of that reassignment process. So if someone could be aligned with between their DSNP and their Medicaid plan in that reassignment process, they were selected and realigned in that process. We also have our health plans moving toward implementing seamless conversion in their DSNP plans, and one of those has recently received approval to be able to do that. And then we are implementing very extensive member education programs to really help educate members about why it's important for them to choose to have the same plan for both Medicaid and Medicare. So it has been an evolutionary process. We revise our agreements every year and look for new opportunities. I will say that since we really began tracking and measuring our progress, which was 16 months ago, we've moved from having 22,000 aligned members to having over 29,000 aligned members. So about a 32% increase in 16 months. We're really pleased with what we've been able to accomplish both from a contracting and a membership perspective.
Okay. Thank you, Patty. Elizabeth?
Hi. I'd like to just take a moment to encourage any state that is contemplating this to be patient with the large body of knowledge about Medicare that's before you to master. So it almost has to be incremental in terms of just getting up the learning curve for Medicare for the first time. So New Jersey has been in a DSNP contract for 3 years, and we have kind of a shrinking pool in New Jersey. Our approach to alignment is to use only those contractors that are with us for Medicaid managed care, and New Jersey just got into managed long-term services and supports last July, so that's kind of a new component that we're looking forward to adding in completely next year. We just at a contract level, we have a pretty highly integrated MIPA agreement with 2 out of our 5 current New Jersey family care contractors, so we do not require a SNP contract, but we do require all SNP contractors to be with us for Medicaid managed care. And we have an ongoing member alignment in that we leverage our ability to auto-assign on the Medicaid side to maintain ongoing complete alignment of membership. So when a member approaches a DSNP to say, hey, I'd like to enroll, Medicaid automatically places that individual in the same company for Medicaid. So we always have everyone under a single roof. We use only full dual eligibles for the enrollment. We have a dual subset option that helps us align with Medicaid full dual eligible categories here in New Jersey. And we've really used a $0 cost share as an incentive to bring members into it so that they can experience an aligned program. We're really very highly aligned at an administrative level. So just to give you some flavor of that, we have a single ID card. That has been a big benefit to the members. We hear positive feedback about that. We have an integrated online provider directory that has been tremendously helpful to stakeholders, members, and their caregivers. We offer that one-stop enrollment I mentioned, and we do cover all acute, primary, and chronic care for members, and that's been tremendously helpful to have that all under one roof with a really one-stop single care coordination entity within each SNP that can manage across Medicaid and Medicare for anything that the member needs. Associated with that single care coordination hub within the DSNP, we also expect all of our DSNPs to have a single person at an administrative kind of government affairs level to manage the two halves internally of their organization if they don't yet have a specialized unit. We have seen a lot of migration toward a specialized unit among our DSNPs to handle this particular product, and we encourage them to have a single point of contact that keeps everything bridged and smoothly running for our SNP members. We also offer nursing facility managed long-term services and support starting this year. So we're really incrementally building out from acute, primary, and chronic into home and community-based long-term services and supports. And because we are so integrated on the administrative side, we felt it was important to build out a little bit slowly into managed long-term services and supports, just so we feel that we get it right for the member and there's no disruption to continuity. In terms of an evolution, again, we kind of being in this not so very long, it started out as just sort of a contract for us to manage in year one in 2012, and it's really evolved into a program level philosophy here in New Jersey, and we've really realized that as a state we need to master what it means to understand Medicare managed care. We've had to, out of necessity, construct a really highly integrated closeout process. So I would encourage, just because we're still working through refining the STARS program at a national level, I would encourage any state just getting into DSNP to construct an integrated closeout plan just right from the get-go. That has been an evolution for us after having lost a few plans. And then we really moved into requiring a single ID card, realizing that it really helps, especially at pharmacy point of sale. And we have a really highly integrated marketing review, and that assists us greatly with oversight of marketing materials, and also we require integrated appeals and grievance materials. And also we do have a highly integrated enrollment process that allows us to use Medicare data to really verify enrollment and eligibility information, and that has been a real evolution in how well we understand our own eligibility requirements, enrollment requirements, and mechanics. So we feel that over time we have a really much better product than we started with, and we've really seen that in enrollment growth over time. We have a really strong, about 6% per month average, and so you may find that it is a very popular option.
Okay, Elizabeth, thank you very much. Pam and Sue, you want to tell us about Minnesota?
Hello, everyone. This is Pam. We, of course, have had many years to develop these programs, and so we started in different places than where Tennessee and New Jersey have had to start. And the one advantage we had was being able to set up our programs as aligned programs from the beginning. But we have developed some tools in doing that I think would be helpful to other states as well. We use the same plan for both Medicare and Medicaid. We procure that way. We require that. Once in a while it gets a little disconnected because of the procurement cycles, and if a plan drops out or something, and we have to try to true it up again with our procurement, and that can be challenging given the long time frames that it takes to align with the Medicare side on that, but we've been able to do that. We run our program. We actually have two programs for seniors that are integrated. One is a voluntary program that's fully integrated with Medicare. The other is our mandatory program that is integrated with MLTSS, but not with Medicare. So we have made those two programs work together. There's one contract for both of those programs, the mandatory and the integrated, fully integrated program. And we require our DSNPs to apply to CMS for what we call a dual eligible subset that matches our Medicaid enrollment exactly. So they really aren't allowed to enroll anyone that doesn't match that Medicaid criteria that we have. And we do have a few exclusions in that population that are left in fee-for-service, not very many. But it does help a lot in the level of integration that we are able to achieve, having the plans do that subset. That is available, I believe, to SNPs. So any state starting out might want to require their plans to do that, or require that they move to that so that they only enroll the people that are on the Medicaid side. We use integrated enrollment form and an integrated enrollment process so that the choice for the integrated program is on that form. They do have one card, as does New Jersey. We have reached a very high level of integration in addition to all the features that have just been talked about by the other two participants here. We have also integrated our models of care. The billing for providers is generally integrated. The member services are generally integrated. We coordinate our assessment and care planning for our MLTSS with the SNP models of care, and the HRA, the health risk assessments that the SNPs are required to do, are built into our electronic MLTSS system. We of course get encounter data, including Part D encounter data. So there are, we've been able to reach a very high level of integration. I would say that in terms of how we've evolved, in some ways we were more integrated 20 years ago than we are now. Though we've been able to hold on to most of our features, but 20 years ago it was much simpler. As Medicare adds more requirements for DSNPs, and as Medicaid has more expectations on the MLTSS side, it becomes more challenging to keep everything aligned and integrated. So we have to constantly be watching for very small, sometimes little things that could change our picture here, and then have to negotiate with CMS. Since we have entered into a DSNP demo now with CMS, we're the one state that has had that opportunity. We are working to we have a contract management team now that meets regularly and is very valuable in watching for those little things that can get disintegrated. For instance, we've been able to utilize more member materials that are integrated and improve those member materials. We've always had them integrated, but now we've been able to improve that. We have a joint review process with CMS on our member materials, and so there are a number of areas that we've been able to achieve. I don't think that a lot of the areas that we've been able to achieve integration in, or more integration, let's say, are not areas that require waivers for DSNPs or require demonstration authority. We put them into our demonstration to kind of have it all as one package. And there are very few things in that demonstration that are not really allowed in, between states and health plans under MIPA contracts. And so we're excited to see the new call letter that just came out having from Medicare, having some new opportunities for other states to have some of the same features that we've had in our DSNP demo and extend some of those to other states and make that more clear to everyone that those things are possible outside of demonstration status.
Well, Pam, thank you very much. Let's go to our next slide on information reporting requirements. And this will be the last topic before we shift to questions from the audience. But I think, as Elizabeth mentioned, there's an awful lot of stuff out there on Medicare that states heretofore have had no reason to become familiar with. And there are, as Becca mentioned, a lot of opportunities for states to request information from DSNPs that is easy for them to provide because they're providing it to Medicare anyway. But the key issue is, do you have people on your staff in the state that can make good use of that information? So in the interest of helping states that are at earlier stages and want to be a little bit selective about the information they request, let me ask our panelists, number one, what kind of information has been most useful for you? What kind is less useful? And what are some examples of what you've been able to do with this kind of Medicare information that you would not otherwise have been able to do? And anybody who wants to start can start.
So this is Patty. I think from the Medicaid agency perspective, hands down, the most beneficial information for us has been the encounter data. And that's because, heretofore we've not had access to that Part C data in any way. So we went through a very extensive process with all of our DSNPs of creating the capabilities for them to submit to us encounter data just as we require our Medicaid health plans to do, so that we now have that full picture for all of those members who are served by a DSNP. From our perspective, that information has been very useful just in terms of analyzing utilization and understanding and helping to set policy and program priorities. I think there's tremendous potential to really look at evaluation strategies to be able to compare quality and cost effectiveness of care depending on whether a person is served in original Medicare, Medicare Advantage, non-DSNP or DSNP, if we can get access to that full range of information. I do want to say though that I think, and by the way, we also have a medical informatics division that uses all of that data extensively, and so having the people who have capacity to analyze that is really, really critical. We share that. We have the ability and permission to be able to make sure that our health plans have information available to them for coordination of care purposes using encounter data, and so that information is made available to them. But I will say that I think two other pieces of reporting and notification, even beyond the things that are listed here, have probably been even more beneficial to us as it relates to the member's experience of care. And one of those is really making the health plans work together. So we have three DSNPs that are also Medicaid plans. We have three DSNPs that are not Medicaid plans, and that was a conscious choice on our part to not require those members to move out of those DSNPs, which sort of predated our efforts toward alignment. But we require all of them to communicate with each other. So, for example, they are contractually required to provide notification to another Medicaid MCO DSNP when a member is admitted to an inpatient setting, whether that's a hospital stay, whether that's a SNF stay. That DSNP has to tell the Medicaid health plan, and then both of them are obligated contractually to coordinate with each other regarding discharge planning. So instead of the automatic path being hospital to SNF to NIF, now it's hospital to let's think about whether HCBS is really an option for this member, and can we avoid that Medicare SNF stay and that Medicaid nursing facility benefit. So that piece of notification to each other has been really, really important. And then even probably more basic than that is even if you have a plan who is both a Medicaid managed care organization and a Medicare D-SNP, it doesn't necessarily mean those two plans are working together unless you create expectations that they integrate their systems so that the person who is coordinating care, and this is particularly true for members who are receiving Medicaid long-term services and supports, that care coordinator has access to all of the things that are happening with that member at the Medicare benefit level and can timely coordinate. So we're not waiting for encounter data. It's that Medicaid MCO care coordinator who's notified of the hospital inpatient admission and who can begin to engage immediately. So part of it is notification to themselves and really integrating those systems so that their staff have that information readily available to them.
Thank you, Patty. Elizabeth or Pam or Sue, do you have things to add to that?
I would like to add, this is Pam, how important our reporting from the health plans of the bids has been. The health plans are, in our MIPA contract, are required to provide their Medicare Advantage bids to our actuaries. We use that and our actuaries then review that as part of their rates development. They use it for cost avoidance to make sure that we're not covering something that the plan is providing as an extra benefit, or to look at what the administration costs are in the Medicare side, and we try to leverage, of course, since the health plan on the Medicare side is required to do their model of care and a certain amount of care coordination, especially for the non-MLTSS population. We rely on that care coordination that they provide through the D-SNP for those populations, and we don't want to be overpaying for that. We use it for allocation of administrative costs. The health plans also provide the risk adjustment scores to us so that we're able to see those periodically. Gives us a better idea of where they are and what the financial viability of the whole picture is here. And we also require, of course, that there are public financials that they have to report, that we get what their MLRs are, their medical loss ratios are, and we look at that across the whole program in an integrated fashion. They report that on an integrated basis to our licensing agency. We also, of course, rely, like Patty said, on the encounters. We also get the Part D encounters and have an analytics division and analytics resources on our team that has been really critical. The other area I would just note would be models of care. Having the plans share the models of care with us has been critical. They have developed integrated models of care. We, under the demonstration, have been allowed to add state MLTSS requirements into those models of care and to review them and actually approve that section of the model of care. I'm hoping that will be one of the features that could be available to other states that we've now tried out through this demonstration. It doesn't seem like it's an impossible process. It's worked really well for us, and we're excited about having that ability to make sure that the models of care that are developed by the plans have to accommodate our MLTSS requirements, and to be able to work out if we do see any disconnects in the state and federal requirements for the models of care, that we can work that out with CMS. So I would say those are some of the key issues. There's a lot more, but I'll let Elizabeth talk.
Hey, Elizabeth.
Yeah, that's an understatement, Pam. There's so much more to cover in this world of Medicare and Medicaid. I would add to what Patty and Pam said, especially along the encounters line. New Jersey receives Part C and Part D encounters from the plans, and we do extend that to require all of the $0 encounters. So if it's something Medicare just doesn't pay for and they're crossing it over to Medicaid where the service will be paid for, since we have a pretty extensive Medicaid benefit here in New Jersey that is sort of mutually exclusive from Medicare, we do receive all the $0 encounters. And that has been really helpful in looking at utilization patterns within this integrated space. Along the benefit line, we require the plans to disclose to us what they are going to submit in their supplemental benefit package. So kind of adding on to what Pam talked about in terms of bid filing, we work with them now to, and this is part of the whole evolution, we didn't do this at first, but we found that it's necessary to understand where they're going to submit the kind of fringe benefits along with their regular Medicare package so that we can work with them. Sometimes those supplemental benefits sort of tread on a state plan benefit or a waiver benefit and can have an adverse, sort of a hidden adverse impact, especially on waiver beneficiaries if they start uptake of that benefit outside of the waiver. In some cases it can affect eligibility, so we do encourage attention to that. Another area where we've been really keenly interested is in having them report all of their HEDIS measures to us. And from that reporting on the quality side, it has helped us develop better insight, kind of more global insight into where we can do more as a state to leverage our position as a partner in the MIPA contract to support high-quality performance that not only supports their performance as a plan and kind of in STARS terms, that's our hope long-term, but supports positive outcomes for members. So if we see, for example, low scores in care for the elderly or medication reconciliation on the Medicare side where so much care is happening after, say, a hospital discharge, then we certainly have an interest as the state partner to be very involved in making sure that the quality is top-notch from our side, too. And then we require low-income subsidy renewal data. We get that anyway, but we really take a look at it. And then we work closely with the plans to coordinate member outcomes on the enrollment front. So I'll pause there.
Okay, thank you very much, Elizabeth. Let me turn it back to Anne Mary for any questions we may have from our audience.
Thank you, Jim, and thank you, Patty, Pam, Sue, and Elizabeth for sharing your state approaches for increasing alignment between DSNPs and Medicaid programs in your states, and for also sharing your strategies for other states to move towards an integrated program for Medicare and Medicaid enrollees. So we are now going to open up the floor for any questions for our featured speakers today. Feel free to share your questions through the Q&A feature, or you may go ahead and pose your question now. We're going to go ahead and unmute your lines. Just give me one moment. And in the meantime, we did get a question come in through our Q&A feature. Jim, you can answer this one. The question is, if there are particular provisions
you are no longer muted
to be sent out as examples of DSNP requirements, contract requirements, for data sharing and care coordination that was discussed earlier in the presentation. So folks could have access to those provisions.
You are now muted.
We've got a lot of examples of specific contract language in the TA tool itself. Plus, we have links to the full DSNP contracts from all 12 states, and the DSNP tool itself, in the summaries, indicates the page numbers or the section numbers in those contracts. So if you're looking for specific language on specific topics, you ought to be able to find your way to that in the TA tool itself, at least the contracts for those 12 states we looked at.
And we have another question. If a state does not have Medicaid MLTSS plans that can be aligned with DSNPs, what benefits are there for states in contracting with DSNPs?
You are no longer muted.
I think there are a lot of benefits. This is Pam, and I think Elizabeth has probably got comments on this too, because your whole chronic and
you are no longer muted.
Your therapies and rehab is all coming through Medicare for people with dual eligibility. And if that isn't well managed, even if the rest of the folks are in fee-for-service Medicaid if people are in fee-for-service Medicaid for their long-term care services, you're still going to be better off working with the DSNPs to be able to encourage better care under the chronic care and acute care and primary care pieces of the system to influence the rest of what they're doing with your population. It's so critical. Well, I don't know.
This is
Patty. Go ahead, Elizabeth. That's fine.
Okay. Well, I'll be quick. I think I'll let some of our beneficiary testimonials answer that question, in that, New Jersey does have a high degree of integration that has been critical for members who do have chronic conditions, including behavioral health care needs, and caregivers of individuals with developmental disabilities really love this program, and they have said, before I was enrolled in DSNP, everything was so hard. This has been such a lifesaver. It's taken the hassle factor out. I feel like I have more energy to actually care for my loved one because I'm not doing all of that coordination for the chronic care, which can be very intensive. One couple, I just love them. They both have behavioral health care needs, and they were both enrolled in a SNP. And they said that when they go to their meetings, their DSNP enrollment is always number 1 or number 2 on their gratitudes list. And so I think that just speaks very well of how powerful this benefit can be for people with chronic conditions. Others have said, the savings I get on the $0 cost share, which is an option for MIPA contracting, has been a tremendous help to them financially. It allows them to take better care of themselves. And so there are so many ways from a beneficiary perspective that this is a great option for states that may not have an active MLTSS program. And then from the state's perspective that, Pam covered, it's wonderful to be able to have leverage into that Medicare world that we wouldn't have otherwise.
And I think that Pam and Elizabeth have covered this topic completely, so I agree with everything they've said.
Okay, we have another question coming in from Ohio. Ohio does have a demo and allows DSNPs to market in demo areas since Medicare Advantage plans can do so. And the question relates to whether states limit DSNP contracts outside of the DSNPs that are integrated through aligned Medicaid and DSNP plans. This relates to what our state panelists discussed earlier, but it might be good to clarify.
So this is Patty. I think I raised the issue earlier. We actually had DSNPs already in place when we really began our alignment efforts. And while we've contemplated the potential to really limit DSNPs only to those plans that also have a Medicaid contract so that they can really cover the full range of benefits for members, we've been hesitant to do that largely because of the potential disruption for members, and honestly, quite frankly, as well as political issues that would likely be raised in that process. So we are not interested and will not contract with additional DSNPs that are not our Medicaid plans, but we to date have allowed those other contracts to continue, although we certainly engage in education efforts to help members understand the benefits of choosing to be in an aligned plan.
And we have another question that came in. For plans that require, through the procurement process, their Medicaid plans be or work towards having a DSNP contract, how long do you allow them to achieve DSNP status, and can you share required milestones? So if any of our state panelists have any thoughts on that from your experience.
So this is Patty again. In our recent procurement, which actually began a little over a full year, it began late in 2013 for a January 1, 2015 implementation date. We required that all of the proposers essentially commit to having a companion DSNP plan, and in the course of working through the logistics of that and the timelines of Medicare enrollment processes, ended up giving them until 2016 to have a fully operational statewide DSNP. I will say that one of them is already fully operational statewide in 2015, and the second lacks a few counties. So we have two that are fully statewide, and one of them already was. Another one who is statewide and one who is very close to that.
Thank you, Patty. Does anyone on the line have questions? The floor is open. Feel free to pose your question.
I just had a follow-up question to the prior one. There was a little bit of noise, background noise. So you required the plan to commit to achieving DSNP status, and how long did you give them?
So the procurement process occurred in late 2013. And we technically ended up giving them until 2016 to have a fully operational statewide DSNP. One of them actually achieved a fully operational statewide DSNP by 2015, and the other one just lacks a few counties being at that point. And the other one already was statewide.
Okay, thank you.
This is Pam. I would just add to that, one has to be quite aware of the length of the CMS process for that and build that into your planning. The plans who want to enter the market or who want to change their service areas have to notify CMS of that, usually in November of it's almost, what is it, a year and a half prior, Sue?
Yeah, it's November of the year prior to the year they want a contract.
Right. So, and then the following spring is when they would put in their submission
for the 1st of January the next year.
Yeah, for their, and then they have to go through the bid process and all of that, and that isn't even finalized until October of that following year. So then the problem is you have to back way up from that for the state to do its procurement way ahead of that. So, you know, about 3 years is probably what you have to think of for that cycle, and though once in a while it can be done more quickly. And that same goes for the service area changes if you want them to expand or go to a different service area. And so that whole, the logistics can be worked out, but if you have a planned dropout in the middle of that or something, you know, you risk the problem of having no coverage of integrated program in certain areas of the state and things like that. So what Patty's doing, they're requiring them to be statewide or making sure you have choices in the plans and things that is a good idea, but it does take pre-planning. It can be done.
This is Elizabeth. I would just add on to everything that Pam and Patty have mentioned to say that in that process, when a plan seeks a service area expansion in the state, it's important for states to understand that Medicare is not viewing that expansion unless it's a plan that only exists within your state. CMS is looking at Part D and Part C expansion approvals, and they're looking nationwide. So something that happens, if you're on the East Coast, it could be something that happens in a plan on the West Coast or vice versa. That is kind of a ding against the plan's performance. So even though you have expectations that the plan could expand statewide, CMS may differ on the final approved service area. So you may have to go through a couple of these rounds that Pam talked about in that timeline before the plan is finally approved. And all of that is assuming that their performance is such that they can sustain their ongoing service in your state service areas. And then CMS also looks a couple of years back. So the performance that is evaluated for whether a plan can expand is always about 2 years old, like 14 months look back, something like that. and it doesn't necessarily have to do with what's happening in your state alone. So it's just another thing to think about, and maybe have some communication with the CMS contracts group if you're interested in what's going on.
That's a great point, Elizabeth, and I'll just add to that. So if you're approaching this from a procurement perspective on the Medicaid side and you're looking to have plans that have the capacity for alignment, a piece of what you may want to consider as a part of your procurement process is whether that plan's quality performance in the Medicare program would allow them to expand their service area or to establish in your state. Those are things that you probably need to think about.
Yeah, and their past performance, so their STARS and past performance to be looking at. Past performances, warnings about that are posted online on Medicare.gov. And it's, like Patty said, very important to keep abreast of that, because a plan that you admit today could be gone next year if their performance isn't such that it's sustainable according to CMS.
Hey, thank you all for joining in the discussion, and thank you to our participants for sharing your questions. Those are some really good questions, and we really appreciate you joining us today. If participants on the line would like to revisit the conversation and the slides, we will have a recording of the call and the presentation uploaded to the Integrated Care Resource Center website. We will also be sending out through email a recording of the presentation, ICRC's new TA tool on state contracting with DSNPs, and a summary document of the TA tool. As Jim and Rebecca mentioned earlier, we are very excited to share the TA tool with all of you and welcome you to refer to it as a resource for your own state. The link to the tool can be found at the top of this screen. And the other resources, I also highly recommend you visit them. They include some basics on SNPs and DSNP contracting. We hope that the study hall call today has been valuable to all of you. Please take 30 seconds to fill out the brief questionnaire that will pop up when you exit the presentation. It would be a huge help to us as we develop new resources related to DSNP contracting. Thanks again to our presenters, our partners in CMS, and to all of you for joining us today. Thank you.